Okay, we are live.
Good morning, everyone. Today is April 29th, hard to believe. This is a joint meeting between House Healthcare and Senate Health and Welfare. We have a number of guests with us for testimony this morning, and thank you all for being here. We also have Ledge Counsel and Joint Fiscal Office here in case we need some legal or fiscal advice. So thank you too for being here. We're starting out this morning in talking about some of the pressures that we're seeing on healthcare costs. We're looking first at the insurance premiums, insurance costs, and what's going on in that whole area. And then we're going to, we'll also then be looking at some of our independent providers and what's happening to them. We'll come back a later day to look at hospitals and talk with them a little bit about the pressures they're feeling. So good morning, Commissioner Pichak, and I can't thank you enough for taking time out of your day for being with us and providing us with some information about the cost-benefit ratio. What is happening with our insurance carriers and with folks out in the real world, depending on those carriers for payment.
Great. Well, thank you, Madam Chair. It's my pleasure to be here. I have a presentation. I'm going to share my screen with everyone. I believe you'll have this presentation in your folder as well, but I'll go ahead and do that now.
While that's coming up, Senator Lyons, could I just say briefly that Representative Donahue will not be able to join us this morning because there's a Rules Committee in the House that conflicts, and the House members will be needing to leave the joint meeting at just before 10:30 because we have a 10:30 House session.
Okay, thank you. Thanks for that reminder. We'll struggle along without you. Commissioner Pichak, have you got it going, or we're patient?
Morning.
Technical
Morning,
difficulties.
Good morning.
Senator, while he's doing that, and just as a reminder, myself and David Durfee will plan on staying on past 10:30 if we need to.
Excellent.
Right. Thank you.
Oh, good.
Yeah.
That's great. Thank you.
That is what we had arranged.
Good.
Oh, there we go. I think it'll work now.
It's coming up.
And I will move that and do that.
Thank you.
Great. And is that visible for everybody?
It's perfect. Thank you.
Yes.
Great. Sorry about that technical difficulty, but again, thank you everybody for having me join, and I'm happy to talk about the impact as we're seeing it on the commercial insurance marketplace. You know, we really I want to provide just a brief overview of some of the work that we're doing as well. We're providing, I'm providing the same overview to the Green Mountain Care Board this afternoon at 1. So I just thought it might be valuable for your committee to hear this full report as well. But of course, the focus of it will be on the financial impacts, the second part of the presentation. But I did want to overview DFR's emergency actions taken to date. I know Jill Rickard from our department testified last week relating to some of these actions, but again, just wanted to put the full context for you in front of the committee. So as it relates to this sort of stakeholder process, I just want to reiterate that this really has been a collaborative and thoughtful process. Sebastian Arduengo, who's on our team, he's done an exceptional job bringing these stakeholders together. So has Emily Brown, who's also on our team. The two of them have held weekly stakeholder meetings to discuss policy, to discuss operational matters. I think we probably had a meeting with this group before March 9th, but since March 9th, we've had weekly stakeholder meetings. So that constant and consistent communication has really been key. Representatives from the commercial insurance industry, representatives from the provider community, representatives from AHS, state Medicaid, DEVA as well. So that's been really important. I also want to thank the legislature as well. We feel well supported from a legislative standpoint. Everything that we needed that we didn't already have authority for, we were able to get in Act 91 that was signed into law at the end of March, particularly, as you all know, relating to telehealth, cost treatment for COVID, and cost sharing for pharmaceuticals. Those were the elements that we didn't have a particular authority on, and we got that authority. So just wanted to say thank you, and I'll update you a little bit about what we're doing under Act 91 as well. But I think this is just key. I mean, this collaborative process is important at any time, but it's particularly important during a crisis, and it's challenging during the crises to have this kind of process and this kind of collaboration. So I do, again, just want to thank all the stakeholders and thank our team for the good work that they're doing. Even though it's a crisis, and even though things are unpredictable and volatile, I feel like they have continued to march in a very measured and thoughtful way to make good policy for Vermonters. So that's a really good thing to see. So again, just to breeze through some of these, if you have any questions, don't hesitate to chime in, because I'll go through them somewhat quickly, because I think you're familiar with most. But in early March, we issued a bulletin about the cost of testing. So we were instructing all insurers to cover the cost of COVID-19 testing, and that's regardless of if they went to a hospital emergency room, to an urgent care facility, to their doctor's office. We thought it was really important at that moment that there were no cost barriers to people accessing testing. Similar guidance came out from Medicare and Medicaid as well. So the state also committed to picking up the uninsured population. So that was a pretty broad applicable action there, but at least as it involves commercial insurance, we thought that was a really important step forward early on in the pandemic. Once the state of emergency was declared, and as we were building up to the stay home, stay safe order, we also thought it was important to issue Bulletin 210, which was relating to prescription drugs. So this allowed people to get a refill early. So basically, they always had on hand the option of a 30-day supply of drugs. So if you were, for example, if you were a couple of weeks ago waiting to get your prescription filled on May 1st, you could have went early and gotten your 30-day prescription refilled, just so that you always had at least a 30-day supply of your medication on hand. And pharmacists were also had more flexibility to go broader than that as well. So again, as we were telling people to not make as many visits to the pharmacy, not make as many visits to the grocery store, people might have been afraid to leave their homes, thought that was very critical to make sure they had access to their medication and supplies that were beyond what the normal process is. We also arrived at an agreement pretty quickly after that, again, relating to telehealth. This was not a mandate, and we couldn't address the audio only piece from our authority, but we were able to get broad agreement from the commercial health insurance marketplace about the coverage and the reimbursement for telemedicine. So as people, again, were either directed not to go to the hospital or their doctor's office, or were afraid to go to their doctor's office or hospital, many routine visits still needed to occur, and even many screenings for more serious issues needed to occur. So I think that was a really important policy initiative as well, and we formalized that, as you all know, under our emergency rule just a couple of weeks ago. So if we skip ahead here, you'll see that, we also did things that were less newsworthy, but I think equally important. We suspended routine provider audits by insurers. So we really thought it's important that doctors, hospitals, providers are able to have their full focus on the pandemic, that they're not responding to audits that are looking at periods of time from 18 months ago or whatever the period of time might be, that is certainly important work to make sure there's not fraud or other malfeasance going on. But certainly during the pandemic, that work could be suspended until there's more capacity and bandwidth to do it. Similarly, on the suspension of the credentialing process for insurers, we thought, as we're expanding telehealth and as more people are coming into the system, more providers potentially are coming into the system, that they should have more quick credentialing process so that they can get reimbursement through commercial insurance. So again, another important piece to the telemedicine component as well. In
Can I
late
ask a
March,
quick-
yes.
Just a quick question, and this relates, I think, more to the federal guidance regarding any audits of federal dollars that are going out. Do you have a sense of what the federal guidelines are for audits post-emergency to evaluate the use of the funds that are coming to us?
Yes,
then-
under the CARES Act.
Yes,
Yes,
Well,
that's a
that's-
really good question. And I think it's just a little too early to know for certain.
okay,
I think,
I-
right now, certainly making a good faith determination about what the law says, what any guidance says from any agency about how the money can be used, documenting your rationale for why, this money fits that description, and then
Yeah.
ensuring that you have all the documentation to back up how you spent the money. I mean, that across the board is good guidance for anyone receiving federal money during this period of time. But it's really uncertain what that process will look like. So something that we have to keep an eye on, and that's applicable to us at the state as well as other entities as well.
yeah, thank you. I didn't mean to interrupt your flow. And
No
I'll
worries.
try- Okay, go ahead.
No worries at all. So we also talked in mid-March to late March about requests to insurance companies provide reasonable grace periods for those that are unable to pay their insurance premiums. There's already grace periods built in under the exchange, but we talked about expanding those grace periods so that there were not individuals that had their policies canceled. Each insurer has looked at that a little bit differently with flexibility, but they've all told us and they've committed that those that are in financial hardship will not have a non-payment issue result in the cancellation of insurance. We'll have to see how long the pandemic goes on for and how long the financial issues go on for as well, and how much flexibility can be provided. But that's obviously an important component as well, at least for the short term, that those that have lost their jobs or have lost their income, they may be eligible for Medicaid or other insurance, but others, small businesses might have difficulty paying their premiums. There is an ability to have some flexibility if you're having a true hardship, similar to our banks and credit unions, the flexibility that we've asked them to provide, that if you are in true financial hardship, you should reach out to your financial institution or your health insurance company to see what can be done. And then lastly, just on these actions here, taking us through late March and April, we formalized the telemedicine rule, like I mentioned, store and forward means, telephone, traditional telehealth as well. So that, again, is great to see. I think we really view this as a lifeline to the provider community so that they can continue to do their good work, albeit in a reduced and more limited way. But I have heard anecdotally that Vermonters that are experiencing telehealth potentially for the first time find it there's stories both ways, but that they find it convenient and a new way of accessing healthcare that might be more efficient for them. So we'll see what the long-term impact is on telemedicine. But the big one, and again, I want to thank the legislature for working with us to get us this authority. The big one, in my opinion, was the coverage of COVID-19 diagnosis, treatment, and any prevention related to COVID-19. So again, this is eliminating any cost sharing relating to commercial insurance, no co-pays, no co-insurance, no deductibles. And it goes back to when, the crisis started to hit Vermont back in back to the date of the emergency declaration. So basically we'll pick up people, everyone that was in the hospital as far as I can remember in terms of the date of hospitalizations when they started. But again, I think this is an important, policy from a moral standpoint. I think it's the right thing to do. These folks are obviously impacted very significantly. Many people are impacted financially. So taking that hardship off of them. But it's also the right health policy, I think, to eliminate any barriers to people going and getting testing and then going and getting treatment, ensuring that they are able to recover and that we are able to not have the virus transmit beyond that individual. So getting them protection, but also getting protection to their communities, their families, and friends. So eliminating those cost barriers are important for us to continue to get our hands wrapped around the pandemic generally here in Vermont. So that's an important piece of health policy.
Commissioner.
Oh, yes.
I'm sorry. Representative Houghton has a question, and I don't know whether
Yes.
it's about what you're currently discussing or something you've just mentioned. So I'm going to interrupt you and hope you
No
can
worries.
remember where we are.
And it can wait till the end, but it is specific to one of these emergency rules.
Why don't you ask it now, and then
Okay.
we'll see how that flows.
Okay, so with the emergency rules specific to covering telehealth, telephone, or store and forward means, this relates directly to cost sharing. It doesn't seem to say anything about reimbursement. I know in the Act 91, we require reimbursement for the telephone and telemedicine, and we did not require it for store and forward. I'm just curious if your bulletin does anything for reimbursement for store and forward.
So I don't want to misspeak. I'll get an answer for you, a specific answer for you, and get it back to the committee. But generally, I'll tell you that the intent was to have telemedicine, telephone only, audio only, and store and forward covered in the same way that traditional in-person visits would be covered. That was the intent.
Okay.
And so basically to have the coverage be as broad as in-person visits or in-person consultations. So I would think
So I will just say I have heard from a couple doctors who are indicating the store and forward is not being covered. So before I respond to them, when you have a moment, if you could get back, that would be great.
Yeah, for sure.
Thank you.
Laura, you'll also have an opportunity to talk with some of the insurers going forward, and we can see what their response is as well.
Yes, thank you.
Okay.
So we have a bulletin just last week clarifying out-of-network ambulance services, that when an out-of-network ambulance service is provided for emergency medical treatment to a member of a commercial insurer, it's our view that the Vermont law requires the health insurer to reimburse the ambulance provider directly for the cost of the services rather than sending the payment to the member, which can get complicated both for the member and for the ambulance service as well. So that is a bulletin that was just issued last week. And then I did want to update the committee also on the emergency rules or the emergency rule on pharmacy cost sharing. We continue to work with the stakeholders. We're continuing to discuss this internally. I think as we've talked to at least some of the folks on the committee about, there is an opportunity for people that have lost either their income or their job to get on Medicaid, and they would have better cost sharing situations, not just pharmacy, but other medical services as well. So that's one option that's currently available that we're just trying to understand the impacts around that. Another practical consideration is that many people on maintenance medication would have met their $1,400 annual deductible at this point. So that's a practical consideration that we're working through as well. So we're trying to find a resolution. I anticipate a resolution, let's call it in the next week, about a narrowly tailored emergency rule that would address the committee's and the legislature's concerns without being overly broad and picking up potentially some of this cost sharing when there are better alternatives available to a consumer. So we're still working through that, but we've made some good progress over the last couple of weeks. And like I said, optimistic that we'll get a narrowly tailored solution to brief the committee on within a week or so.
Thank you.
So those are all the, oh yeah.
Representative Lippert has a question before you move on.
Yes. So this is just to, so first let me say, I tremendously appreciate the work of DFR and the collaborative way in which we have moved forward, in which you have moved forward on an emergency basis to issue a number of bulletins and emergency rules. It's greatly appreciated by myself and our committee. Absolutely. I think one of the things that is also, as we've worked through this, one of the things that has been, this process has made clear, I believe, is that in fact, the Department of Financial Regulation and the legislature do not in fact have the ability to have emergency requirements of all commercial policies in the state of Vermont. That in fact, policies which are self-funded are beyond the reach of the legislature, and I believe beyond the reach of the Department of Financial Regulation. And so we have heard through previous testimony that many, and we've often heard that many of them self-funded policies choose to adopt requirements that the legislature sets forth, or emergency requirements that DFR puts forward, but that we do not have the ability to require them. Am I correct in that understanding? And then
Yes,
a follow-up. Yeah, go ahead.
Oh, go ahead. Sorry, I'll finish. I'll answer both. Sorry.
Yeah, and so I've raised this question in a previous testimony, but I find myself again wondering whether in fact we run afoul of federal preemption in being able to understand the breadth and who are the self-funded plans in the state of Vermont, and what requirements that the state has imposed either through emergency rule or through legislation to know which self-funded plans in fact adopt which policies and which ones do not.
So I'll answer that first part, and you're absolutely right, Chair Lippert, that there are limitations on, I'll just call it the state's authority, whether that's the legislature or our department, around these basically self-funded ERISA type employer plans.
Right.
You are right also that, and again, it's not a universal, I can't say this universally, but you are right that when employers, if we get a complaint that comes into our department and it's an individual in an employer group plan that's self-funded, we don't have really any authority, but sometimes we'll go to the business and say, listen, this is covered under Vermont law. It's a mandate under Vermont law and it's not covered under your plan. Will you, will you consider that? And oftentimes they will consider that and change their policy at their business. But again, I can't say that's universal. And I will also say that, and Blue Cross Blue Shield, I know, is testifying, and they can speak to this as well, that many of the employer plans are closely resemble the state and federal mandates as well. But again, it's not on a universal basis. So we do have limitations there. And I'll just be honest that it from a substantive standpoint, of course, from a health policy standpoint, it can get frustrating. And also from a communication standpoint, it can get frustrating because we want to tell people, for example, that your treatment is covered, but that's only true if you're in a commercial plan that is fully funded. It's not true if you're in a self-funded plan because we can't extend it to those plans. So it does cause a communication challenge as well. That is frustrating for us as a department, but for Vermonters that are trying to understand easily, what are they on the hook for and what are they not on the hook for? As to the point, I don't want to again misspeak, but as to the point about how can we identify employers that are participating? Let me get back to you on that because there's certainly limitations on our authority, and those limitations are generally quite broad. The one area, so I will just get back to you instead of trying to express my views on that and provide you some analysis.
Can let me ask a sort of a follow-up question, because this continues to be an issue for all of us. But the question is, as you are looking at the solvency of individual carriers, what the information that you collect must also include the work that they're doing with some of the self-insured.
Or does it?
I mean, that's a question. Does it or does it not include that information?
Yeah, so I can, it's actually a good segue because if I go to the next slide,
Okay.
We're talking about the financial impacts. And for example, you'll see in the Blue Cross Blue Shield group, we have Blue Cross Blue Shield, MVP, and Cigna, and these are all public information about their financials as of the end of 2019. But just look at that total revenue number, if you will, and just for Blue Cross Blue Shield, it's 537 million, and that's their total revenue. But they don't have all the risk for that premium. Some of that premium is in different categories, but then additional to that are self-funded plans as well. They have revenue from a third-party administrative standpoint, but then there's also premiums that are being collected by employers as well that are not necessarily part of that figure. So, we are familiar with the scope of it, and we're familiar with the extent of it at each one of our insurance carriers. Sometimes it's hard to decipher from their financials, but basically, they don't own that risk. So that risk is off of their balance sheet, if you will. It's on the employer, but they do get some of the revenue in terms of third-party administrative services that they're providing or other similar services. So just wanted to make that distinction.
Thank you. That's
So
great.
So on the financial piece, the main point here is just to show that each one of our insurers entered this crisis in a strong financial position. We rank insurance companies, as you probably know, by something called risk-based capital. It takes into account the risk presented to each insurer, how much in revenues they have, how much premium they write, what's their total surplus, what's their specific risk profile. And it's a universal measurement across the country. So just giving you a range here, since the specific number is technically confidential, but anything in the 500s is a solid number. Depending on the risk profile, you might want to see an insurance company in the 600s as well. But again, Blue Cross Blue Shield, MVP, and Cigna were all between the mid to low 400s to the mid to high 500s. So all very acceptable conditions for these companies. If the numbers get low enough, if they get to a point, for example, that their risk-based capital is at 200 instead of 500 for Blue Cross Blue Shield, I'll just use that for an example, then we have certain regulatory obligations that kick in. If, for example, Blue Cross Blue Shield got below 375, though, there are certain obligations that kick in from the Blue Cross Blue Shield National Organization. So these numbers are solid, and they're far away from any of those regulatory or other impacts. And that's certainly a good thing to see going into a financial and health crisis. I'll say the same thing, even though this is not the purpose of this, but our banks and credit unions also entered this in strong financial positions. So we're also fortunate from that perspective as well. So this is where they all stood, prior to the pandemic at the end of calendar year 19, again, all in strong position. But I want to walk through just what are some of the financial impacts that COVID-19 has brought on the health insurers. All of these items that are dotted in red and a negative, that's sort of explaining that it's going to have a negative impact on their financial position. The positive and the green is saying that it's going to have an impact, at least on health insurers, it's going to have an impact in a positive direction on their financial condition. So first, we have COVID-19 claims, testing, and treatment. So these are items that were built into the reserves. They were anticipating, pandemics or other large health crises. That's part of what the reserves are there for. But obviously, it's not really built into the rates in the sense that they're not anticipating in a given year to have a health crisis like this. So those are items that are going to have a negative impact on their overall financial health. When it comes to testing, it's both the testing that has occurred, but then also consider that every state, including Vermont, needs to ramp up testing as we start to reopen our states. So the testing will continue to be a prominent item and a prominent cost for insurers and for others as well. And then, of course, the treatment that has already occurred, but there's a lot of variables about how the disease progresses between now and when we have a reliable vaccine. But we could see a low grade sort of spread throughout basically the summer, fall, winter. That could mean that there are people sort of constantly in the hospital getting treatment for COVID-19. Our numbers stay low, but basically it doesn't burn out here and go away in Vermont. It just is something that we're living with. And of course, that's going to have a financial impact for insurance companies. It could also spike back up in the fall or in the winter, the second wave that many health professionals are talking about. That could have an unknown impact from a financial standpoint on the treatment as well. So again, we know that there are costs there, but we also know that they're variable as well, and they could be manageable or they could be quite severe. So I just want to point that out. We also obviously are thinking about their investment portfolio and the performance of their investment portfolios. Many of the health insurers across the country, and same here for the ones that operate in Vermont, have limited exposure to the equity marketplace. So, the equity marketplace stocks, for example, are what really took a hit in fiscal year 20 so far, and year to date, stocks are down on the S&P close to 16%, I think, or somewhere between 11 and 16%, but we'll get into a slide about that in a minute. So that certainly is having an impact on their financial performance. The emergency regulations that I mentioned, for example, the treatment is one thing, but then eliminating the cost share, obviously, just as an example, is going to have further impact on their financial position as well. Again, we think it's the right policy decision, but certainly has the potential to have an impact. Under the
Commissioner.
yes.
Commissioner, we've got two hands up. They've been up for a little while.
Oh, sorry.
So that's okay. I was hoping we could get to a little spot to ask a question. I have a question, and then Representative Durfee has a question. So my question is, as you're going through all the red here on the slide, is there also, do you have a sense of the federal dollars that will be helping cover some of these expenditures, either through CARES 1, 2, or 3 going forward? Yeah.
It's a good question. So health hospitals and providers have money coming to them under the CARES Act. So I'll let the folks that represent them explain that in more detail. But as it relates to health insurers, there has been no payment. There's been more obligation under the CARES Act. And I'll give you an example, which is, under the CARES Act, it says that commercial insurers have to provide a vaccine that's considered a preventative service. Right. So that would actually be an additional expense that, commercial insurers have to be on the lookout for, rather than money coming to commercial insurers. For example, the CARES Act also talked about serology testing having no cost sharing. So again, that's an additional expense for commercial insurers rather than money coming to them. So it's likely I think it's probably fair, since that's the direction that the CARES Act signaled, that they're talking about putting more financial burden on health insurers, that they're unlikely to get, any federal stimulus money. And again, I think that's, for our condition, for our situation, I think that's fine. Our health insurers were coming in a strong financial position, so they can weather this. And it's just a matter of, how severe some of these markers are to determine, how severe or how close to the line they might get.
As a follow-up question, and then I've got a lineup for you. I have Representative Durfee, Representative Houghton, and Representative Rogers on my list. But just as a very quick follow-up, if, for example, the hospital is under the $100 billion available to providers, is accessing a payment for treatment for a specific patient, then does that relieve the insurer for that patient of that expenditure?
I want to think about that a little bit.
Well, we'll keep following up on that kind of question, because I think it's something that going forward, when you look at the balance sheet after all this emergency is over, we're going to have to understand what the balance is.
Yeah.
Okay. All right. Representative Durfee.
Good morning. And Commissioner, my question is actually about the previous slide, and I wonder if it would make sense to wait until you're done and back talking about the financial conditions at the moment or looking forward of the carriers. So I'll hold it, if that's
Great.
Okay.
Representative Houghton, I think, is next.
And mine's an easy one. Just the presentation that is actually posted to our committee pages is not complete. Some of these financial slides are missing. So if you could have someone in your office, just make sure to send in a correct one, that would be great, so other people can view it later.
Yeah, sure. I bet you what
Thank you.
happened is I
No worries.
converted
Thank
it from PowerPoint to Word or PowerPoint to PDF, and it probably didn't download all the slides in time.
No
So I'll be
worries.
sure to do that.
Representative Rogers has a question before you move ahead.
Yeah, thank you. I just was wondering about reinsurance and kind of the conditions for when reinsurance would kick in, and would a COVID situation trigger that?
Yeah, so it's a good question. So I can tell you, for example, when, there are health insurers that have captive insurers, that sit on top of them, and they basically act as reinsurers. And they do have pandemic related, whether they're catastrophe bonds or whether they're other sort of, reinsurance vehicles. So basically, if a pandemic strikes and you meet the criteria, then you have an extra set of cash available to you. That's not something every health insurer has set up for themselves, and I think we can let each of the health insurers speak to whether they have a reinsurance strategy specific to pandemic. But if they don't have a reinsurance strategy specific to pandemic, then that's likely not going to factor in here.
Okay. So in other words, the strategies that they have might be more of a response to an individual with high healthcare needs as opposed to a population healthcare occurrence.
Yeah, so they ultimately, really are relying on the reserves as their sort of stopgap. You do have individual employers that have, stop loss policies that sort of act like reinsurance for the employer, that the commercial insurance company is going to take on that risk. They do have captives that are also working to, help them shift some of that risk again into different areas. But when it comes to pandemic, most of the time that's a specific sort of risk, and you really would have had to have a specific reinsurance strategy for that. So again, I'll let the insurers speak to whether they have that or not. I don't believe that any of the ones they're speaking today do, but I don't want to misspeak for them.
Thank you.
Representative Page has a question.
Yes, a couple of questions. One regarding the financial aspect for testing for the COVID-19 virus. Are there specific tests that you cover? Because there is some controversy about those tests out there. Some of them may be more valid than others. And then the other question is, and this maybe tags along with what Representative Rogers was saying, preparation for the future. If this pandemic continues into the fall and beyond, what then? Is the state and our insurance companies, are they prepared for this pandemic to perhaps go on further?
Yeah, so on the testing front, there are a lot of different tests, particularly in the serology testing. There hasn't been widespread serology testing in Vermont yet. Dr. Levine and the team that's advising him have found that it's not reliable enough. And there are mixed academic studies out there about the reliability of the serological testing. So that is on this list as a negative, but it has not happened yet. We haven't had widespread serological testing. On the sort of the diagnostic testing, those are tests that there might be a variety out there, but those are the traditional tests that have been administered, from the beginning, the ones that are being administered in Vermont. So those are the ones that, there's some comfort in their accuracy and their quality. So that hasn't been an issue from a diagnostic testing standpoint. Again, from a serological testing standpoint, there is a lot of split on how effective they are, but we haven't started that kind of widespread testing in Vermont. I think you asked the question about how well positioned are we. So, I'll be frank that anything can happen. this can turn in a way that we're not anticipating. It can become more severe than we're anticipating. But this is the whole reason that the insurance companies have these reserves. We talk about them, year in and year out when things are in a good financial position and there isn't a health crisis, and you think, well, why do they have so much money? It seems like that might be excessive, and I can understand why that seems that way, certainly. But it's really precisely for these kind of moments that they have these well-capitalized balance sheets so that they can comfortably and confidently say, a year from now, if a lot of these worst case scenarios develop, we're still going to be here. We're still going to be financially sound. We're not going to be as sound as we were before the pandemic, but we're going to be able to weather the storm. So I have confidence that every one of these insurers that are operating in Vermont will have the ability to weather the storm, even if it gets more difficult and more severe. And that again is due to their good financial management, due to the fact that they have these reserves that will help them and help Vermonters ultimately, because their health insurers are going to continue to exist. So again, the only caveat to that is anything can happen, and things that we're not anticipating can happen as well. But they're as well prepared as a health insurer could be.
Okay.
So the one thing I haven't touched on is sort of this item that is a positive for health insurers, but a negative to providers, and that is the reduction in non-COVID-19 claims. So obviously, as elective surgeries have been postponed, as other in-hospital procedures have been postponed, some of that is getting picked up by telemedicine. And I want to flip through very quickly some slides that talk about that on a national level, but it's not obviously being completely picked up. So that is obviously an impact on the provider community in a negative way, but it is having a positive impact in the short term here on the health insurer community. The big question on that is this a reduction that is basically shifting procedures that would have happened in March and April to June, July, and August, or August, September, October? Or will these procedures get pushed out even further into a different plan year? Will these procedures not happen at all? So that is to be determined. So we don't really know the true impact at this point on the health insurers or the providers. The other thing, of course, that's happening, and Dr. Levine talked about this last week, is people are not coming to the hospital for more routine wellness visits, or even when they have symptoms of serious medical conditions, they're waiting because of fear and concern about going to the emergency room. And that is creating a situation where people are presenting with much more severe cases, medical episodes, than they would otherwise in normal times. And that also has an impact from a financial standpoint. A more severe medical condition, regardless of what it is going to be more complicated and more expensive to treat than one that is dealt with earlier and intervened earlier. So that's a dynamic that we have to continue to watch closely as well. That could have a negative impact within the health insurer community. So I think the big takeaway here is that they're in strong financial condition. There are a lot of unknowns. There are a lot of variables. There are a lot of unknowns in terms of the total expense of some of these items, and there are unknowns in terms of the timing of these items as well. So we'll do our best. We have weekly calls as well with our health insurers, separate from the stakeholder calls, to talk about operational issues and financial issues. And we'll continue that indefinitely and into the near and long term, because it's important, again, for us to have as regulators, it's really important for us to have our finger on the pulse of what's going on. So again, just this, oh yes.
Commissioner, Senator Westman has a question, and then we'll move on. I also have a question, but I'm going to hold it till later. Senator Westman.
So here's my question around a piece of what you said. Have you worked with the Green Mountain Care Board to see what the capacity of particularly hospitals are going forward? I've heard the claim made that as soon as we get back to a normal state, there'll be this big bulge of people that put off their elective surgeries into the future. And at my small hospital, we have 3 surgical rooms. Before this, they were always at capacity. And what I'm looking at is when they open back up, they only have those 3 surgical rooms, and they're going to run at capacity again the way they did before. So how can they create a bulge?
No, you're absolutely right. I mean, that's a consideration that has to be taken into account. Is basically this pent up demand for service. It will be real and it will be true, but there's a capacity issue at hospitals, maybe all hospitals, but certainly some hospitals, about how many treatments, how many surgeries, how many procedures they can do, even, you know, in sort of an extended time period, whether they, you know, have longer hours or longer weeks. It's still a capacity issue. There's also this issue.
I don't like doing this, but I understand that this conversation is going to go on after we've heard from the hospitals and providers as well. And I'm looking at the time that we have, and I know Representative Lippert has I hope, a quick question. I'm going to suggest that we have Representative Lippert ask his question, and then we hold our questions so that we can complete the testimony that we have in front of us. We've got a long way to go this morning. So with that plan in mind, and unless someone has a really urgent question about understanding, I think we'll just move ahead. So Bill, you get the last crack.
Well, just quickly, what's the frequency of DFRs receiving reports from the insurance carriers on their reserves? Is it a frequency throughout the year? Is it only on an annual basis? Is it a monthly, bi-weekly?
Yeah, so in normal times it would be certainly annually, but then also quarterly. We have monthly check-ins as well, I think, that are sort of separate from the financial reports. But in these times, we are having those kind of conversations on a weekly basis.
Okay, thank you.
So I will just again quickly get through, put some price tags on some of these numbers that I mentioned. So the Center for Medicare and Medicaid Services has a reimbursement rate of $35 to $51 for a non-CDC approved test on the testing side. I've seen some national hospitals that are charging more like 150. I saw one that was 100 just last night, but 150 to 200 for a COVID lab test. So this is just to give you a sense of the cost of some of these things. Again, we talked about the requirement of screening under the CARES Act. The Hospital Association can certainly provide more information on this, but some nationwide estimates put the figure at a per patient cost of about just under $40,000 for inpatient treatment with an average length of stay of 6 days. I've seen other estimates that put that number over $70,000 per patient. So again, it just gives you a sense of you know, how costly some of these claims can be on the COVID side. Flipping ahead on the investment portfolio, if you remember, we talked about this also. So this shows the total investments and cash of each of our health insurance companies. Again, you can see that they have a limited exposure to equities and alternative investments, but they have the greatest exposure to the bond marketplace. And then a lot of them hold a significant amount of cash as well. So again, if you just look at this quickly, you'll see they're averaging over 50% on the bonds. They're somewhere between single digits to 20% on the equities. But if you factor in the alternative investments, they're all probably right around that 20% mark for equities and alternative investments. And then they're all holding some amount of cash on hand as well. So again, this is a snapshot from the end of 2019. If we fast forward to how we're performing year to date, the bond performance is mixed. There are bonds that are performing well year to date. There are others like corporate bonds and low rated bonds and what they call high yield or junk bonds that are not performing well. So that's a mixed bag, but generally not a bad story. They're performing at least even, if not a little bit better. But it's really the equity marketplace that's down, you know, from the year end. You can see here just the chart from S&P 500, which is a broad-based fund that represents the 500 largest companies in the US. And you can see it's down significantly. It's down 3-month change, about 12%. But the stock market has had a better month in April. So some of those investments are coming back this month. And I'm sure you recognize that in your own retirement portfolios as well. But again, that's having a financial impact on the health insurers, ultimate strength. Again, we just talked briefly about the financial impact of the emergency actions. So not only is the treatment cost about, let's call it 38,000 to maybe more than 38,000, but there are no cost sharing allowed under that again. So that's going to have a cost to the insurance companies. And then again, these preventative items that we mentioned previously, the preventative services of the vaccine and serological testing at zero cost share will have some financial impact. This is the stuff I just want to breeze through, but I think it's important for you to see. This is an example of the number of visits to ambulatory practices as a percentage from April through about a week and a half ago. Again, this is on a national basis. This is not specific to any of the carriers in Vermont, but you can get a sense of how significant the decline is, close to 60% drop in visits to inpatient hospital visits or other provider visits. So that's a rather significant number. The next slide shows that is different in different parts of the country. And New England has had the greatest decrease in these kind of ambulatory visits. And I think that's probably because we in the Northeast have had a more severe, an early and more severe experience with COVID-19. We across the board had earlier bans on elective surgery. We probably also, just because we've had more cases in the Northeast, have people that are not wanting to go to the hospital like we talked about. But you can see there where the New England and Mid-Atlantic, we're that lowest percentage. It's really closer to 65% as a region. So again, going back out to the national level, you can see here that we have the drop in in-person visits, but then you can see that telemedicine or telehealth is picking up some of those visits, but not all of them. So you can see here that the decline in in-person visits is steeper than the decline among visits of any type, which includes telemedicine and in-person. So telemedicine is helping, but it's certainly still leaving a pretty big hole, as I'm sure the hospital representatives will talk about, or the provider community will talk about as well. So I think that's the end of the presentation. I'll go back to unsharing my screen if I can figure that part out, but I'm happy to take any questions in the meantime.
Thank you, Commissioner. This has been very helpful. We greatly appreciate it. We understand the ongoing work that you're doing with stakeholders, and know that this is just the beginning. It is a long haul for us. Representative Durfee does have a question. I will hold my questions until another day, because we have a number of folks following you with testimony, and we again thank you for taking the time, and also to Sebastian and Emily for the work that they've done. I know they've been working on this as well.
Yeah, they've been exceptional.
You're lucky.
Yes.
Representative Durfee.
Yeah, thank you, Commissioner. I had a question earlier when you had the slides up showing the piece of the balance sheet for each of the three carriers, and I was surprised to see just that MVP was bigger than Blue Cross and Cigna significantly bigger, and I'm guessing that's because in Blue Cross's case we're only looking at Vermont, but with the other two carriers it's looking at something larger, or is that not right?
Yes. So if you think of so those were their balance sheets of the whole company.
Yeah.
Blue Cross is just in Vermont. MVP they have a piece of their business in Vermont, but they have a much larger presence in New York. And then Cigna is a much larger company than either of those two. So that really accounts for why you see those differences.
And does that, so that just makes me wonder then how you're obviously only able to regulate how they do business in Vermont. Do we look at numbers broken out? Are the carriers required to do that, and so that you can see what a Vermont balance sheet looks like? Is that even meaningful?
Yeah, so what we do is they have to file rates with each of the states. So the rates have to be representative of the costs that Vermonters are experiencing in Vermont.
Yeah.
But ultimately, for us, it's Blue Cross Blue Shield. We're responsible for their solvency. But for MVP, it's New York, the state of New York, the insurance commissioner in New York that has to make those determinations. And in Cigna's case, it's Connecticut. So ultimately, it's the ultimately us state regulators play a team role in regulating the industry. So we have a role in Vermont of regulating the rates for all of them to some degree, but it's ultimately their home state regulator that's regulating their solvency. We are in touch regularly with other states regarding that. And during the rate review process, we ask them, do they have solvency concerns for any of their companies? And that's obviously an ongoing dialogue if there are issues, but they don't, we haven't had any issues with any of these companies.
And then just looking at sort of the bottom line of the various impacts, most of them were red and we had the one green impact. And knowing that there's still a lot of questions about the future right now, today anyway, is the bottom line
Right.
positive or negative?
Yeah, it's a great question. I wish I could tell you the answer, but like I said, there are these two variables. It's the severity of basically each one of those lines. So, we know how many tests we've run today. We know how many people have been in the hospital, but those numbers are going to change over time. So, again, how severe the pandemic is, how significant our testing ramp up is will really impact that line ultimately. The investment, if the investments come back, then that won't even be a factor anymore. But, the economic piece of this is unknown. So unfortunately, there's just so many unknowns and variables that it's hard for me to say, how does this wash out? And if it washes out positively today, in a month from now, it could be a very different story. So we need to just exercise sort of constant surveillance and some patience in terms of figuring out how this is going to shake out. But I think the big line, the top line story is that all three of these carriers are in good financial shape coming into this, and we're confident about their ability to continue to deliver their services.
Okay.
Good. Thank you. This has been terrific. And I should have said earlier that Sebastian and Emily are also very lucky. Thank you for your time.
I think I'm much more lucky.
Okay, we'll debate that. Thank you very much, Commissioner, and good luck this afternoon at the Green Mountain Care Board.
Thank you. Thank you for your help.
I think we move ahead to the insurance carriers, and I also know that the House members are looking. Sure, go ahead, Bill.
Can I interrupt just for a second? I'm realizing that this morning's session is a House caucus of the whole, not a floor action where the House is in session. And so it's my understanding that members can choose whether to continue with attending the joint session of our committees or leaving and joining the caucus of the whole. There are two Senate bills that are going to be reviewed in the caucus during this morning's caucus of the whole for the House. So I would leave it to individual members to choose whether to continue on this Zoom joint session or to adjourn yourself and join the caucus of the whole.
Okay, thank you for that. And I'm going to establish the ground rules for the next testimony, and I would like for everyone to hold questions, please. We have we're a little bit behind schedule, but I'm not feeling uncomfortable about that. I think if we can get the next insurance carriers and our healthcare advocate testimony, that we will still have time for our independent providers as well. So unless you have a question of understanding, let's hold questions till the end, and that would be good. So I have Sarah Teachout of Blue Cross and Blue Shield is on our agenda next. Sarah, you lucked out again. You're first and you're muted.
Okay, thank you.
Okay.
Sarah Teach out for Blue Cross and Blue Shield of Vermont. I'll start just quickly with some guiding principles that Blue Cross had as we entered this pandemic. Our main goals were to protect our members, providers, customers, and employees, and to do our part to flatten the curve. We wanted to provide reliable services and communications to those same groups, members, customers, and providers during this uncertain time. We wanted to collaborate with all parts of the state healthcare system to ensure a coordinated and efficient response. We wanted to contribute to the broader community and healthcare system solutions, both in the short term and the long term, and we wanted to respond quickly and in cooperation with state policy directives and objectives. So we feel that Blue Cross and Blue Shield of Vermont provided a strong supporting role in the state's healthcare system response to COVID-19. We want to continue our operations at the highest level of service. That includes customer service, claims processing, care coordination, operational changes in communication. We revised a large number of our policies to support providers and public health and to strengthen the delivery capacity. And we have member reserves to pay for new unanticipated healthcare costs for COVID-19 testing and treatment. So now I'll speak more specifically about our reserves and our premiums, which I believe is what you were requesting. So I think obviously Michael Pichek spoke about reserves broadly, but member reserves are required by our regulators to protect people and ensure healthcare coverage in unanticipated crises, such exactly as this COVID-19 pandemic. The target RBC for Blue Cross and Blue Shield of Vermont is between 590% and 745% risk-based capital. And so Blue Cross entered this particular crisis with reserves that were actually below that range. I think you, last time I was here, you asked about Blue Cross's not-for-profit status and profit. And so I thought I would clarify a little bit what happens with what we call contribution to reserves. So each year in the rate review process before the Green Mountain Care Board, Blue Cross and Blue Shield of Vermont requests usually a minimum 1.5% of premiums in a contribution to reserves. This is what I think other companies consider profit. We discuss it as margin that we request to realize each year. This is above the amount of premiums used for member healthcare and administrative costs. If a margin is realized at the end of the year, then that is deposited into member reserves. Margins need to, or member reserves, there's a whole host of factors taken into account to determine if they're adequate or excessive. But one of the things that member reserves need to do is keep priced with medical inflation in order to be able to cover medical costs. So member reserves are used to pay, will be used to pay for all the costs associated with COVID-19. I think I'll state the obvious, but COVID-19 did not exist when 2020 insurance premiums were set last summer, and none of these new costs were anticipated. I think Commissioner Pichek went through all of the costs that we are seeing or expecting with COVID-19. So there's the short-term testing, diagnosis, treatment, and antibody testing, potential additional surges or waves of COVID-19 infections, and then future COVID-19 treatments, vaccine testing, or other costs. So now I'll jump quickly to the short-term drop in services and claims. That was the green positive on Commissioner Pichek's slides. So yes, Blue Cross and Blue Shield of Vermont has seen a temporary cancellation of non-essential procedures and a drop in claims for those. The drop has been different depending on the type of provider you're looking at. It's been much different for hospitals versus professionals or other types of providers. Not all claims have gone away. Providers have continued to have necessary and emergency care continue. And we've also seen a significant increase in telemedicine claims, although it certainly has not made up for the drop in other claims. I provided a chart that Oliver Wyman did for the NAIC, and I can't actually pull it up for you because I can't share the screen, but it's
We
on
have it.
your,
We
you
have it.
Okay.
We do. It's a beautiful
So-
chart.
I didn't do it, but somebody else did. So what is different about health insurance? And I know we've heard a lot about auto insurance claims and customers receiving refunds. The difference is that auto claims are avoided. When people stay home and drive fewer miles, there's fewer accidents. Healthcare claims can be delayed, but few non-essential procedures can be avoided entirely. We do know that probably not every claim will come back, but the vast majority of people need to continue to seek their care. And some care, as the commissioner mentioned, could be more severe due to the delay in seeking care. So there's a lot of unknowns to do with the delay in care and what we can anticipate and when, the timing really about when that care can come back. And we do know that this was a especially significant cash flow issue for providers. The other thing I wanted to mention is that the delay in care and claims is not all, I guess I'll use the term, realized by Blue Cross and Blue Shield, the company. About half of our membership and customers is self-funded employer groups. And so that delay in care is a temporary savings to those employers, not anything realized through Blue Cross. And I think Michael Pichuk also tried to show you some of that when he was testifying. So there's a temporary drop in claims for employers as well as Blue Cross fully insured members, and we anticipate a significant amount of those claims coming back. I did mention the uptake in telemedicine utilization. It's, you know, the data is all preliminary, nothing is final. The rate of growth is significant, but it was starting on a very small number. We have started to see preliminary claims for COVID-19 costs as well, but those have been relatively slow in coming in, and they're not final either. We usually wait 3 to 6 months after a claim period to look at the run out in claims to be ensured that we've captured all the claims for a particular period. This works a lot like what I was familiar with before, tax receipts. There's a lag between when the service is provided and when it's billed to Blue Cross. And we usually try and turn around the claims pretty quickly. And then the last few points I wanted to talk about are offsetting premium factors. So the commissioner also mentioned our flexibility for businesses and individuals that are financially stressed by the economic downturn. And there's a lot of uncertainty about how many businesses and individuals will continue to pay premiums. April premiums are due this week, and May will be crucial months for premium payments to be able to see if individuals and employers have been able to continue paying their premiums. And then the last thing that I mentioned before that is still in the early stages of development, we have created advanced payment programs to both hospitals and independent providers to help stabilize cash flow and enable them to provide patient care. So we're still working on those programs, but the idea is to advance what would have been a normal level of claims. So
I apologize for being the one to interrupt and ask a question, but yes or no, can that or does that include some of your self-insured clients?
Oh yes, you asked me that question before. So what we're doing, yeah, is advancing the money based on what all of their claims were. So Blue Cross is, you know, essentially advancing that money, and then under the assumption that all customers, all members will continue to seek care, and it'll even out over the course of the year.
Thank you.
Yep.
Is that it? Or do you
Um,
have more?
Sorry,
Yeah.
I had one last little bit I wanted to talk about the ACA. So this is specific to the Vermont Health Connect premiums. The Affordable Care Act prohibits insurers from changing premium amounts mid-year, either increasing premiums or decreasing premiums. There's also a specific provision and a protection for policyholders in the event that premiums collected in a calendar year are significantly higher than patient care in that year. At the end of the year, there's a calculation, again, governed by the ACA, to ensure that if there was a financial windfall to insurance carriers, we would have to return that money to policyholders. It's measured by the medical loss ratio known as MLR. And it's a fairly substantial hurdle. So if the MLR was less than 80%, so if we paid less than 80% of the premium back out in medical claims, we would have to refund a portion of the money. So that's the most extreme scenario in protection of the ACA. Annually, when we go before the Green Mountain Care Board, they look at our reserve levels and premiums in the previous year. And they can decide whether or not to keep our contribution to reserves, which I mentioned earlier, at the same level, or reduce them in order to mitigate the impact on members from overcharging premiums. So I just wanted to assure people that there are a lot of regulations and protections in place if premiums charged in this year are more than the cost of medical care. So I think I would end, I guess, on the same note as the commissioner. We're only 4 months into 2020 with a good portion of the year still to go and a lot of unknowns. And the situation with COVID-19 can change extremely quickly. It's just really too soon for us to tell what the outcome of this year will be. And that's the end of my testimony.
Thank you, Sarah. That's very helpful. And this is to give us an understanding of the process, what's going on, and what the pros and cons are, or the risks and benefits, I should say. We've seen the list. So a quick question for Sarah Teachout. All right, we're very good then. We're going to move on to
Ginny,
Brent.
Senator. I'm
Who said
sorry,
that?
it's Lori.
I'm sorry. Yep, Representative Houghton.
I responded late. And Sarah, I apologize if I missed this, but in regards to store and forward, is that something you are reimbursing at this point?
Yes, we are reimbursing for store and forward. Was your question whether we're reimbursing at the same level as?
No, just if you are
okay.
reimbursing at all.
Yes, we are.
And I will say that we're probably going to get back into the telehealth issue maybe this week, next week. I don't know which, but it'll be on our agenda, so we'll be able to bring
Great.
that up again. Okay, we're going to move on to, I have Brendan Papard, but I don't see Brendan Papard here. Is there another person? Brendan Papard. Miranda Motter.
Yes.
There you are. And you represent, why don't you introduce yourself for the record? Welcome to the joint committee meeting. And we welcome you.
Thank you so much, Madam Chair. I appreciate the opportunity to spend some time this morning with the joint session of the committees. I am Miranda Motter and am the Senior Vice President of State Affairs and Policy for America's Health Insurance Plans. AHIP is the National Trade Association that represents health plans across the country, providing coverage to millions of Americans. So I appreciate the opportunity to speak to you this morning and to really focus my comments on a report that AHIP recently commissioned through Wakely to provide policymakers such as yourself some further information that we know about how COVID will impact healthcare costs. So I appreciate the opportunity. And hopefully you have the set of slides there in front of you. And we can walk through some of those.
Miranda, what I'm going to suggest is we have the slides, and it would be very helpful for you to go as efficiently as possible, given where we are with our time.
Absolutely.
And we can always come back to this. This is very helpful to have this report from the Wakely Group. Thank you.
Absolutely. So first, let me say that certainly with the comments from the commissioner already this morning, and with Sarah's comments, really commending the commissioner and the state legislature for the work that they are doing together in a collaborative way, particularly with the weekly and regular communications with the health plans. Certainly, as he indicated and as Sarah indicated, I think there are more unknowns today than there are knowns. And so that type of regular communication and working hand in hand is incredibly important. Let me first say that from our health plan's perspective, no one should hesitate to seek testing or treatment for COVID out of concerns of healthcare costs. And so that is very important. We heard from the commissioner this morning and from Sarah about a number of the efforts that health plans have proactively and quickly taken to make sure that that care is accessible, whether it's through telehealth, waiving prior authorization, making sure testing and treatment is available. So with that, let me turn to the report. As I indicated, AHIP commissioned this report through Wakely. The report was published on March the 30th, and so it included information and data through March the 28th. And what it essentially does is estimate the cost of COVID treatment on private insurers over a 2-year period of time. Let me reiterate also what the commissioner said in terms of unknowns around severity and duration of COVID, and certainly that will impact data and information as we have going forward. So this is really a report for the information and the best information that we have now. I will talk here in a few minutes just about an update to this report, and so I hope that we'll have the ability to come back and share that information in real time, particularly as policymakers there in your state continue to look at this very important issue. So on slide 3, and I know you don't have them in front of them, there is a general statement in terms of what the report found. The report estimated that costs of treatment and testing could range from 55 billion to 556 billion over a 2-year period of time. You'll see information there in the slide on page 3 that links to the full report. And so, you know, to the extent that there's interest in looking more at the Wakely methodology, I'd encourage you to do that. But let me quickly take you through how Wakely determined that number. The report looks at the potential impacted populations. And so that looks at Medicare Advantage, the commercial market, and the Medicaid managed care market nationally. And what the report did is it took a baseline infection assumption of 20%. Looking at the studies, it's anywhere from a 10 to 60% infection rate. And so they took a baseline of a 20% and then looked across those populations and determined that, it will estimate that more than 50 million Americans could potentially be infected. So taking that number and then to the next slide on page 5, looking at the potential on costs, taking again that baseline infection rate of 20%, that shows the 56 billion to 556 billion over the 2-year period of time. The slide after that goes a little bit more into the detail in terms of the cost breakdown. So looking at utilization and then actually the cost of that utilization. So of that over 50 million Americans that could potentially be infected. The methodology assumed that there would be at least 5.5 million Americans that would require hospitalization, and of that 5.5, potentially 1.3 million that could potentially require intensive care. And so looking at those numbers for individuals admitted into the intensive care, that cost on average could exceed $30,000. I would note that the numbers that the commissioner presented earlier, I think his number was around an average of 39,000. per individual. I'll turn to slide 7. That will provide some information about what this report didn't include. So, I think one of the themes of the day, again, is uncertainty and unknowns, and time will only help us gather better information and more informed information as we look at what the cost impact will be. We know that the cost impact will vary greatly based upon locality and states. We heard that earlier from the commissioner, particularly around what Vermont has done in terms of some legislative and regulatory action. The other thing I would note that this does not include real-time information on length of stay and cost for COVID patients. So given the time that we released this report, it looked at a data source that would be very close to a type of COVID claim. So it looked at claims such as pneumonia and influenza to help determine what the cost of that might be. So there will be variation on that. As Sarah talked about, this report also does not show and look at the total impact of delayed or deferred care, given the unknowns around that, when that delayed care will actually get turned back on, how that delayed care and that pent-up demand will work its way through the system. So those are all very important things that the report did not include. The last thing I would note, and again, the commissioner noted this, recent guidance out of CMS clarified that the testing requirement did not only apply to diagnostic testing, so waiving of cost sharing, but it also applied to antibody testing, so the serological testing that he spoke to. And so those are all things that this report did not include, and primarily it's because there have been so many changes and updates to what is happening with the COVID crisis. So going forward, I indicated we are updating the report. We hope to, by mid-May, have a Wakely Report 2.0, which will look at actual COVID claims. It will look at the populations that are impacted. It will look more precisely given some of the knowns that we have now, and the treatment costs, both short-term and long-term. As the commissioner noted, and as we look at vaccinations and immunizations that may come online and what those costs may look like, it will attempt to take some of those into consideration. It will also take into consideration the recent stimulus dollars that have been infused into the healthcare system in both of the packages. And then, let me just spend just a quick moment. Sarah mentioned this as well. One of the things that AHEP and the Blue Cross and Blue Shield Trade Association spoke to the NEIC is related to the rate filing deadlines that are coming online in many states. And I know that in Vermont, it is in a few days. And so really, given the unknowns and the need to have better informed information as insurers are developing their premium, we have asked that as states look at their deadlines to the extent that they can, to be flexible with those, and if possible, to push those back. We are asking a July 22nd, again, to those states that can. And then, to the extent that they can't, to allow as much flexibility for insurers so that they can supplement those filings as we move forward into the summer with more precise and better information about COVID. So let me, on my last slide, on slide 9, certainly we have been working as an organization with many different coalitions and stakeholders, and particularly the Blue Cross Blue Shield Trade Association at the national level, to ask for some policies to really help ensure that individuals and Americans have access to healthcare, but also to stabilize the marketplace. So our approach and recommendations are really a 3-pronged approach, really to make sure that individuals, either the employer directly if they're providing employer-sponsored coverage, or individuals that may get their healthcare through their employer, or in the individual market, to be able to have those dollars necessary to help them continue to pay their premiums with the job losses that we know are happening today and continue to increase every day. So premium affordability, the second piece of that is to make sure that those individuals that don't have access to healthcare coverage today, that they can have access to coverage. So whether it's through a special enrollment period in the states with a state-based exchange, or through the federal exchange for those states that do not. And then lastly, as we look at market stability, I know that the commissioner spent some time talking about what that stability looks like, and to make sure that individuals and employers and communities actually have a stable health insurance marketplace, to have a tailored mitigation risk approach that we are talking to policymakers about. So with that, I know I walked through those slides very quickly, but I would again like to offer, this is our preliminary information, and to the extent that we can, we'd love to come back and share some updated materials, either through myself or through Brendan, to provide you all the best information as you're making these decisions, critical decisions each and every day. So thank you for the opportunity.
Thank you. And as you were saying what you're going to be doing next, I had written down a question saying, are you doing that next? So it's nice to know that that's happening. Will the data that you collect be by state?
So Senator, that's a great question. The data that we will be collecting at this point in time will be more of a national picture. To the extent that we can, help sort of look at that on a state level, we can try to do that. But our it will be a national picture, similar to the first report.
Okay, well, thank you. That's helpful. The other question I have is in terms of the data collection, will there be a differentiation between those states that like ours that have a prospective payment program, and many of our insurers, including Blue Cross and Blue Shield, are involved in that prospective payment? Is there a way to make that distinction in the data gathering process?
So again, that's a great question. That is, let me go back and get a better sense of if that is something that the actuaries in Wakely are taking into account, and get some information back to you.
That would be very helpful. Thank you. And as this report gets completed, it would be helpful to know that it is complete, and perhaps, I don't know what our schedule is, but we certainly would like to have a look at that report. Thank you.
Wonderful. Thank you very much for the opportunity.
Well, thank you. All right. Susan Grakowski is here. Susan,
Yes.
Thank you for your patience.
Oh yeah, no problem. Whenever I try to start my video, it kicks me out. So I think I'm not going to take a chance on being kicked out. So you're
we miss seeing you.
Yeah. Okay. So what I'm going to say, I think you've already heard from Commissioner Pichak and Sarah at Blue Cross. As far as the impact of COVID on premiums and reserves, it really is too early to tell. We're only just a few months into it. But our rates are due to be filed with the Green Mountain Care Board for the 2021 QHP plans in about a week, May 8th. So those rates will be our best expectations and predictions for what's going to happen in 2021. They're not intended to make up for what's happening this year. So we definitely have fewer dollars going out the door at this point, which, as you've heard, is due to providers delaying routine care to focus on COVID. They will be scheduled eventually, whether or not there's going to be a surge and the capacity for surge, nobody exactly knows. But at some point, that care is all going to get to be rescheduled. So in addition to fewer dollars going out the door, we're having fewer dollars coming in the door, with either employers closing just because their businesses are no longer viable, or employers that are staying open that are not able to pay their premiums due to loss of business. So MVP has been reaching out proactively to employers and individuals because we want to keep them with us. We want to keep them insured. So we've done things like relaxing our grace period rules to help prevent members caught in the crisis from being terminated. We're now up to a 90-day grace period. I know Diva had asked us to go from the pre-established 30 up to 60, and now we're up to 90. So we've done that to try to make it easier for small groups and members to be able to pay. So we've increased outreach to groups that were delinquent and are working with them on payment plans. We've actually helped prevent several Vermont small groups and individuals from being terminated last month. So again, being proactive there. So we are doing special outreach to individuals, and we've changed what we call our late letter notice. The letter that would go out if somebody is delinquent in their premium, to provide additional information on other lower cost options that they might have or might want to consider that might make it more affordable to them. And we've beefed up our customer service teams as well to handle the calls that are coming in. We are also giving people, groups and people, the ability to pay by credit card. So again, that keeps the member with us, gives the member a little more flexibility on how they're going to pay that. We have been increasing our outreach to providers to encourage them to submit claims electronically and to sign up for electronic payments, which helps get cash directly into their bank accounts quicker. So we're doing that provider outreach as well. So we're closely monitoring the financial impacts that we're seeing. The impact of pharmacy costs have risen due to allowing for early script renewals and moving to 90-day supplies. So somebody now, when they go to their pharmacy, they can get up to a 90-day supply of medicine, whereas before it was basically 30. We're looking at the impact of waiving cost share for COVID testing and treatments. As the commissioner also said, we're looking and keeping a real close eye on investments and investment returns. How is our portfolio doing? And obviously there's impacts to our cash flow with, expansion of the grace period. That's certainly having one. So other financial impacts, higher bad debt we're expecting to happen in the months ahead, and the potential for lower membership due to small groups going out of business and thus lower premium to cover fixed overhead. So again, it's a very, very fluid situation, but our financial folks are keeping close eyes on everything. So those are the comments that I wanted to make. Representative Houghton, your store and forward question, yes, we do cover store and forward. And there was a question that came in, do we have reinsurance? And the answer is no. As the commissioner said, our solvency is monitored by the New York State Insurance Commissioner, and they have minimums that they require. So that is basically, we've got our reserves, and that's what we would be using. So that's real quick, but that's just what I wanted to tell you.
Thank you. That's a good summary of from your perspective, and as we all know, this is the beginning of a lot of information that we're going to have to keep our eyes on. So thank you, Susan. I'm sorry that we can't see you, but we know you're there and we appreciate your time. And we're going to move.
I will get this fixed for next time.
It's okay. Yeah, it's frustrating, isn't it, when that happens? I see that Representative Durfee has a question. If it's a quick question, that's fine. Go ahead.
Very quick question. Thank you,
All right.
Senator. Susan, we heard last week from Diva that they have seen some enrollment increases in Medicaid. And you mentioned that you're seeing some employers going out of business or no longer able to pay their premiums. And I think it might be helpful, not necessarily today, but down the road a little bit, to get some quantification on that, just so that we know what the sort of the direction is, or the scale of it.
Sure. I can see if I can reach out to the Department of Labor. They're probably the ones that have those kind of statistics. So, okay, I'm making a note on that.
Thank you. Good, thanks. All right. We have Mike Fisher here from the not from the Healthcare Advocate. Michael, thank you for being here.
Thank you. Thanks for taking a moment to hear from me. Again, Mike Fisher, healthcare advocate, and I just want to start by we asked ourselves at the Healthcare Advocate Office a few weeks ago if we really knew what was going on in Vermont families, if we really had a good perspective on how many people were having challenges paying their premiums, or how many people were afraid that they would not be able to pay for the care they needed. And I'd like to spend just a moment walking through some of, well, so due to that, we put a survey out into the field over the last 2 weeks. The survey was out from April 12th through this past Sunday, April 26th, so it's very recent. And I'd like to take just a moment to walk through a very high level outcome of that survey, because I think it informs some of this discussion. 2,500 people filled out the survey. About half of the respondents were on Medicare, and about half were on commercial plans. A small number, 224, were on Medicaid, and 56 people were uninsured. Very important disclaimer here. This is not a representative sample. This is a survey of people who chose to answer. And so while I think it's appropriate to make conclusions like, of the people who filled out the survey, this many believe this or experience that, it's inaccurate or dangerous or risky to say, to extrapolate from this set of 500 Vermonters to a broader description of all Vermonters. But I think it's useful just the same. And I think it tells us some of what we already know. 24%, I'm sorry, mix those numbers up. 42% of those who filled out the survey reported that they had lost income as a result of COVID-19. 15% said they were concerned about their ability to pay their premiums, but did not believe at this time that they would have to drop insurance. Only 3%, 71 people, said that they felt that there was a risk they were going to have to drop their insurance at this time. 24%, 601, are more concerned that they won't be able to pay for their medical bills. We've had a decent amount of discussion today about people not getting the care they need. 29%, 736, reported that they are choosing to wait for the professional medical care, and 16%, 398, told us that they were having problems getting the professional medical care they needed. 13% said that they were having problems managing a chronic condition, not including mental health, and 14% said they were having problems managing their mental health conditions. I just rattled through a lot of numbers, and we will get this to you in written form with some conclusions in the coming days. And I want to repeat my disclaimer. This is interesting to us, and I think it gives us a perspective on what's going on in Vermont families. Though I want to caution us not to draw major conclusions. Draw your own conclusions about what's going on in your communities. I think you have your ears to the ground. Yes, I'll keep going.
Go ahead.
The crisis, this crisis tells us a great deal about our social and medical systems of care and the way we finance it. We've all been pulling together to do our best to make our existing systems act like a public health safety net. This is an extraordinary moment. You legislators, regulators, providers, payers, and of course advocates have worked together to do some extraordinary things to get people some of the care they need, or to put it another way, the care we need them to get. It's a different frame. It has been mentioned, the acts that have been taken, such as telemedicine, to improve access. and reducing financial barriers, copays and deductibles that otherwise are broadly recognized as mechanisms that suppress or reduce care. So those actions, I agree, will put, are putting, and others are putting increased risk on the finances of our payers. On the other side of the equation is all of the care that is elective and scheduled care that is not being provided now. The hospitals report, the Hospital Association tells us that they are experiencing a revenue decrease of 50 to 70%. That's a tremendous number. And I don't know exactly how to square that number with the perspective of the previous couple of witnesses about the risks to their reserves. That reduction is a reduction in medical claims. The giant question before us is what happens next? I agree it's too soon to tell, but I predict that we will see three types of outcomes play out in the coming days. The first, I just needs to be said out loud, though I'm hopeful that it won't be a major dynamic. There will be some tragic stories. There will be people who did not receive the care they needed as a result of this crisis. And here I'm primarily talking about non-COVID care. And there will be tragic outcomes. I say that in part because I know the people who are experiencing that want to be recognized. In addition, I agree about the two broad other perspectives. Generally, will we see a flood of pent-up need of even sicker people? I think that is the concern expressed by the payer community. Or will we see a slow increase as people feel more safe and our providers slowly open their doors, but that some of that non-COVID care that didn't happen during this time will not come back or not come back soon. And I think generally that is some of the perspective I'm hearing from the provider community. We will, of course, only know the answer to that after it plays out. I'm sure we'll see examples of all three, but for what it's worth, my opinion is that it's going to take a longer time for medical claims to come back to what they were previously. The crisis, when we move from a crisis mode to a management mode, notice I didn't say normal, it's going to take some period of time for claims to come back to normal, or come back to what they were before.
Michael.
Yes.
Thank you. This is great.
Yeah.
Do you have other information?
I just want to say that you've heard a lot about the business side of things today, and for good reason you asked this question. I'm of course concerned about the marketplace for our insurers, and of course concerned about the stability of our hospitals. But I'm really chiefly concerned about people's ability, your constituents, our neighbors' ability to get the care they need. And I'm going to sound a little bit like the old activist Mike Fisher, but I just have to say it, and it'll just take me a minute. Our structure of our healthcare financing system is not equipped to deal with this crisis. We have a provider system that's seriously at risk of going broke because they are responding to the crisis. We don't know exactly what's going to happen to the payer system. Maybe the claims won't come and they will have higher surpluses. Or on the other hand, maybe they're right and the claims will come. And at this very moment when more people have lost income, they will be seeking to raise insurance rates. So this is an old wish, aspiration, but in a new context. We have to have a healthcare financing system that can meet the needs during the crisis. No other time has it been so crystal clear that your access to care protects me. I know that many of us are motivated by a much more of a humanist approach, but even if I am wholly motivated by self-interest, we have to move towards a system that assures me that everyone you come into contact with has access to care. And thank you for allowing me a moment to express that aspiration, but I think it's really important that we say it out loud.
Terrific, thank you. And I think that you're talking to a group of people who are extremely aware of the fact that the sort of the negative aspects of our healthcare system are being exacerbated as we go through this strange pandemic and this strange time. And it is about access for people, and that we will continue to look at the information you provide us, and we look forward to that survey. We'll also be continuing our work around hospitals and independent providers, and we're about to take up independent providers. So thank you very much, Michael, and keep us posted on any additional information that you get. I know it's early on in this whole area, but we'll look for updates, and we appreciate your time. Thank you.
Thank you.
All right, and Susan Risdon is here, as is Hannah Rabin, and I want to thank you both for being patient with our time this morning. It is typical legislative time, but I think we have sufficient time this morning to hear from each of you as representing our independent providers. And so I'm going to just turn it over, Susan, as Director of Health First. Are you going to lead us through the testimony? And you're muted. And you're muted. There you go.
Hear me now? Okay.
Yes, we can. Thank you.
Thank you, Senator Lyons, and to the committees for allowing us to speak today. I'm actually going to, my name is Susan Ridson. I'm the Executive Director of Health First Independent Practice Association. I'd actually, if it's okay, like to let Dr. Hannah Rabin speak first and talk about the experience of her practice, Richmond Family Medicine, and then I can fill in some of the blanks after she speaks.
Terrific, thank you. Welcome, Dr. Rabin.
Thank you, Senator Lyons, and thanks for this opportunity to speak to all of you. I'm Hannah Rabin. I'm a family doctor, as Susan said, at Richmond Family Medicine, which is a small independent primary care clinic in the center of Richmond Village. We've been in practice for about 9 years here. And I've been practicing medicine in Chittenden County for about 20 years. I want to just share with you a little sketch of what it's been like to provide primary care in Vermont in the age of COVID, and to talk about some of our innovations and some of our challenges that we've experienced. So I'll tell you first a little bit about the practice. We are 3 doctors. We also have 3 nurse practitioners who provide family medicine care to about 6,000 patients. Additionally, we have 2 part-time psychiatric nurse practitioners, a psychotherapist, a nutritionist, a social worker, and a pharmacist who work with us here in our clinic. We also employ a full-time panel manager who reaches out to panels of patients who may not otherwise be coming in of their own accord to seek care in our clinic. So patients who are perhaps higher risk may have particular socioeconomic situations that make it harder for them to access care. So we're doing a lot of outreach to them, not just waiting for people to come into the clinic. So that's business as usual. We see a wide variety of ages from newborns to the very elderly. We do some home visits. Most care has been provided within our clinic until COVID. So towards the end of February, we realized that we needed to start doing some planning, and quickly. And we developed a three-part strategy to try to achieve certain goals. Our first goal was to continue to provide excellent medical care to our patients. Our second goal was to keep our staff healthy and safe. And our third goal was to be financially viable through this crisis so that we could continue to provide care and to employ our staff as the crisis evolved, and to still be here afterward. We quickly ramped up telemedicine. We are doing now probably about 95% of patient visits as telemedicine visits. That's video or phone, depending on what patients have. We also developed a plan to have a respiratory clinic outside in our parking lot. Initially, it was in a tent. It was snowing some days, it was raining some days. We were evaluating patients out there in the tent, doing heart and lung exams, and started doing COVID testing very early, sending test samples to Quest Labs. And had some of the early positive tests that were seen in the state. We were managing those patients then by telemedicine, sending them home and taking care of them over telemedicine visits. We have been doing blood draws in our parking lot. We still bring patients into the clinic a little bit. Babies who need vaccines and exams, we'll bring them in early in the morning. Sometimes other patients who have acute needs, if an abscess needs to be drained, we'll still bring a patient into the clinic. We wear full personal protective equipment when we're seeing patients at this point in any face-to-face encounter with a patient. And we have ramped up our panel management. So we have phone calls going out to patients, trying to urge them to use this opportunity to try to quit smoking. We've made special attempts to reach out to patients who we know have mental health issues. And we're providing telemedicine visits to care for those patients. Initially, some of the challenges were, obtaining personal protective equipment. We wanted to make sure that when we saw patients, we were keeping ourselves, our staff safe. We were ordering equipment online, visors that welders use. We had donations of N95 masks from patients, and we did get a little bit of equipment from the state, fairly small amounts from the state. We found that our usual vendors had back orders, so it was really hard to get even basic stuff, hand sanitizer, gloves, procedure masks, that sort of thing. And finding surgical gowns was really challenging. There was a lot of support among the Health First organization sharing equipment. So that was one challenge. Another challenge was making sure that we had adequate staffing. We had staff members who needed to be home with children as schools were closing and daycares were closing. So there was a lot of kind of innovative coverage that had to happen for that. Additionally, financially, there was a gap as we were ramping up in telemedicine. I mean, at this point, being able to do a lot of telemedicine visits, many of us are seeing 20 patients a day doing telemedicine, and that's a pretty good volume. But initially there was a gap. So financially, there were some real, sort of scary days where we were very worried about our revenue and ability to cover our costs. We did feel like we, as a small practice, were in a fairly fortunate situation because we actually do participate with OneCare, the ACO, and so we have some capitation. Some of our revenue is capitated. And I would say that for Richmond Family Medicine, it's actually nearly 30% of capitation. And that includes about just under 20% from One Care. That's 20% of our revenue from One Care capitated, and probably just under 10% other capitation, mostly Blue Cross Blue Shield capitation. So in a way that provided a steady stream of revenue for us. However, our fee-for-service charges were down significantly. And so there was a lot of anxiety about how we were going to make payroll. We physicians chose not to take distributions at that time. And that's one way that we were able to, in the early days, make sure that we had enough operating capital to keep going. We did apply for the PPP, the loan, and were granted that loan fairly early. And so we have breathed a sigh of relief, and we have, at least a little reprieve. Additionally, we have received the EIDL loan, HHS stimulus, and the Medicaid retainer. So in terms of cash flow, I think that we're doing okay at the moment. And especially because we also are now, really up and running with telemedicine. I think that the next point of pressure for us financially is going to be after the 8 weeks of the PPP. At that point, if we are able to turn that loan into a grant, that will be very helpful. But at this point, all of that money that we were just talking about is actually an advance or a loan. And it's very helpful in terms of cash flow for a small operation like ours. But ultimately, it's money that will need to be paid back unless we can meet the criteria. And that's another challenge. We're a small practice. We are not, we don't have an accounting department. We have a practice manager who's outstanding and knows a lot about accounting. But just trying to sort through what the requirements are for how we can make sure that that money, the PPP, becomes a grant. Are we going to actually fulfill all those requirements, which changed even in the process of doing that application, how to comply with their requirements. The rules changed. So that's been a challenge. I want to just shift for a moment and explain a little bit about what it's like practicing medicine, doing telemedicine. I had never done a telemedicine visit until now. And it's amazing how much one can do, especially with patients that one knows well. I've been taking care of some of my patients for more than 20 years, since I was a resident. Having that continuity of care, really knowing our people, knowing what their resources are, knowing how to read their facial expressions, it's just really helpful. I was able to take care of a woman last week who had really severe diverticulitis. And I saw her on video. She was in her bed in her bedroom, and I was able to make the diagnosis via video and prescribe antibiotics and follow up with her over the next days and keep her out of the hospital. This was as severe a case of diverticulitis that I've treated at home as I've ever seen, and she's better. I took care of a woman who had a terrible burn, and really, again, the worst burn that I've ever seen. And she hasn't been to the hospital yet. We've been following her along with photographs and messages through our encrypted portal system, through our electronic medical record and over the phone over the last couple of weeks. And I think successfully treating her burn. At some point, she may need a skin graft, but she hasn't needed to go to the burn clinic. So we're doing this kind of care, as well as managing a lot of anxiety, taking care of patients who are positive for COVID, and continuing to provide wellness visits for infants, continuing to manage patients with diabetes and hypertension. So, I think we're doing what we set out to do. I think there are a lot of questions for the future in terms of our financial viability after the 8-week period of the PPP. And so I just wanted to give you that little sketch of what it's been like. And I'm happy to take any questions.
Well, the sketch that you have given us, I will say is, I think it's very optimistic, given the tragedy that we're in and the pressure that you're under. It seems that you have really followed through very well. We thank you for the testimony. I do have a question for you, and that is, you talked about prospective payments. I know you have the loans in place and you're concerned about turning those into outright grants, and that would be great if that could happen. But when you were talking about prospective payments and that you're getting either from OneCare, Blue Cross and Blue Shield, if all of your patients were paid for prospectively, would that improve, would that give you even a brighter outcome or outlook, excuse me?
Well, I think at a time like this, it really does, where there's this much uncertainty and, a dip in patients coming in for care, that kind of thing. Having steady income would allow for, a much, sort of more sure-footed financial approach. So, I would say that in this situation, it's been helpful. I think that, what's tricky is that baked into our capitation payments is some disparity. As independent practices, we have not been able to negotiate for higher fee-for-service rates with the payers. And so when we signed on with OneCare, for example, they looked at our finances and saw what our fee-for-service rates were. And that's been baked into the capitation. So I would say that it's still not fair. This is what I've spoken with you about before.
Yeah.
And capitation, we were always told that, the all-payer model is going to fix this disparity, just wait for the all-payer model. And so we waited for the all-payer model, and then it turns out that, our capitation is actually based on what our fee-for-service had been, with that disparity already set in stone. So we haven't really seen a difference. I know that my colleagues at, who are employed physicians who are also doing telemedicine, they charge the same codes that I'm charging for the same services that I'm providing. And they are also providing excellent care. And I know that their reimbursements are different.
You know what? This is an issue that some of us have been extremely concerned about. I know the Senate Health and Welfare has talked about this, and it could be, as we're going through this emergency, that as I said, the warts are showing up and being exacerbated, and this is one of them. So it's time. I personally believe it's time for us to do an assessment of our rate setting and contractual relationships. I know that's a hard something to swallow for maybe some of our carriers, but we really do need to look at this more globally and make sure that our independent practices are kept whole. It may be that independent practices never reach the level of some of the some other clinical practices, but it's beyond me. And I keep working at it. But thank you, Dr. Rabin. Thank you for your testimony. Any other questions before we turn to Susan? All right, Susan, thank you. And it's Risden. I say it wrong every time. Risden, can you?
Ridson, but I believe
Ridson.
Representative Lippert has.
Oh, I'm sorry. Go ahead.
Yeah, I'm
Bill,
sorry.
sorry.
I didn't raise my hand appropriately in the screen.
I know. I didn't see it.
Sorry. So I'm curious, in terms of Richmond, the Department of Health has just recently released a town by town, their records of positive, COVID-19 positives rates. And I'm curious as to what your perception is of Richmond's through your practice and what else you know. And because I'm always curious as to what the reality on the ground is compared to the data that we see presented.
Sure.
Do
So
you have a sense of the number of COVID positive tests that you've experienced?
yeah, I mean, I would say it's relatively small. I mean, we have 6,000 patients, and I think we've probably had a dozen or so positive cases. Our catchment area is larger than just the town of Richmond.
Larger than, of course it is. Yes.
Yeah.
Yes.
Yeah.
Okay.
So it's much of we have patients from around Chittenden County and even outside of Chittenden County.
Right.
But I think our number of positives has been low. I think Vermont has done remarkably well in terms of our public health approach.
Yeah, I've been struck by, I mean, I'm just trying to understand this, and I appreciate this is not the point of your testimony today, but it's the opportunity to ask, because in our community, I live in Heinsberg, represent Heinsberg, and I think for Richmond, it says fewer than 6 positive tests for Richmond. If that's true, it's good news. If it's, but I'm also painfully aware of in Heinsberg, that's just without putting anyone in any identified people I know well, who clearly would have been tested positive, who clearly were experiencing the clinical symptoms of the COVID-19 infection, and who won't be reflected ever in any data that the health department or anyone else will say was a COVID-19, because the testing was so carefully guarded initially, so anyway, thank you.
Yeah, I appreciate your perspective, and I do want to say that we had really advocated early for more testing and found it really hard to get patients tested, and so we decided to do testing ourselves. And as I said earlier, set up in our parking lot, and we're still doing testing now, but we were among the early independent practices testing.
Perhaps in another time we could hear more about
we
that.
thought it was the right approach.
A quick question related to that, and I meant to ask it earlier. When you have someone who tests positive or looks like they're going to, as you're screening them, what kind of contact tracing are you able to do? How do you go about that? Is that something that you report to the Department of Health, or do you help those folks distance themselves and let others know who they might have had contact with whom they've had contact?
Right. So we do rely on the Vermont Department of Health to do the contact tracing. So we make recommendations to patients about self-isolation in their homes, really specific directions about that, and help to support their families and how to do that in a safe way. But we do have the Department of Health do the contact tracing.
Thank you. Susan.
Yes, thank
Back
you.
to you. Thank you.
So thank you, Dr. Rabin, for your testimony. And Senator Lyons, you mentioned that she paints a bit of an optimistic picture. And I think to a certain extent that is true, because Richmond Family Medicine, first off, is a primary care practice in Chittenden County that's fairly well resourced. And we do have 69 practices in our network across 10 counties, including in some very rural counties, such as Windsor, Addison County, Orleans, Franklin, and Lamoille. So certainly our smaller and more rural practices have really been hit hard. And you saw the numbers from Commissioner Pichak about the declines in the revenue, declines in the patient visits, and certainly every one of our practices have seen that. It's been particularly hard, not only for rural primary care practices, but for all of our specialty practices who are more procedurally based. So like our gastrointestinal docs who aren't doing, screening colonoscopies, our surgeons who are, only doing urgent cases, and so forth. They're ophthalmologists who aren't who are seeing only urgent cases have seen up to 95% reductions in their revenue. That's huge. So they're really having a hard time with this. I will say that those that are able to do telemedicine, of course, are doing them, and that has helped offset some of the losses, no doubt. But again, a lot of these procedurally based specialties aren't able to do surgery, obviously, via telemedicine, so they're not able to recover like a primary care practice is. All of our practices, though, are doing everything they can to keep patients out of the emergency room. They are working 24/7, responding to their patients' phone calls and urgent needs, even more so than they normally do. They're keeping closer track of their high-risk patients just to make sure that they're not ending up in the emergency department when they don't need to. And it's simple things. One of our practices had a patient fall, break their arm, and the patient was ready to go to the emergency department. And the practice said, no, you can come in, we can set it, we can x-ray it here. And they were able to take care of that issue without having them go to the emergency department. I'll also say that about 95% of our practices are taking advantage of the Paycheck Protection Program. And that as well, a smaller percentage are doing the economic injury disaster loans. Those are two programs that are available through the SBA. And many of our practices have also gotten provider relief funds through the Department of Health and Human Services. Without those funding streams, our practices wouldn't make it. So we are so thankful that those funds are there. And I think that is part of the reason why Dr. Rabin, well, I know it is, we have a little bit of optimism where, the hemorrhaging has been stopped for now. So that's, been given us the opportunity to breathe a little bit of a sigh of relief. And I think many of our doctor owners actually got a good night's sleep after weeks of not really sleeping much because of all the uncertainty. Just looking at my notes here. Other things that have been helpful for us, the grants obviously are instrumental. The expanded coverage of the telemedicine has definitely been helpful. I know some of the payers, Medicare, DIVA, as well as Blue Cross, have offered some advances. Those are helpful to a certain extent, although as Dr. Rabin mentioned, you're really just, it provides help now, but eventually you have to pay the piper, and with so much uncertainty, that becomes difficult to ensure. Also, not to mention the fact that, many of our practices were working at capacity before COVID. So you can only work so much, you can only get so many people in. So there's really zero opportunity to recoup the lost income, yet these practices are going to have to pay it back. So our, ongoing concerns, as Dr. Rabin mentioned, is that Paycheck Protection Program ends in 8 weeks. What happens then if we're not back up at full capacity? There's also a lot of technicalities around that program to be able to make it a grant versus a loan. It's really complicated, time consuming, and a pretty high hurdle to reach, especially given all the uncertainty. So we do have concerns around that. We also have quite a few concerns about the availability of personal protective equipment as well as cleaning supplies. We, obviously a ton of that stuff is going to be needed as practices ramp up. Not sure how we're going to get what we need. And Health First has actually been working as part of a coalition with many other healthcare providers in the state, such as Vermont healthcare organizations, I should say, such as Vermont Medical Society, VAWS, Bi-State, Vermont Care Partners, and basically all the players. And we've been talking about ways maybe the state can help healthcare providers get the supplies that they need using their purchasing power there. The other thing, so let me just see here. Other things that would be helpful or ideas is, as I mentioned, grants definitely are something that could be extremely helpful. Be nice if the payers could offer some sort of grant or refund. And I'm of course sensitive to all the uncertainties they face as well. I guess the difference here is that they came into this pandemic. They're reporting that they went into it in pretty good financial shape. That's not the case for many of our practices who have been operating on very thin margins for a very long time. So if there's a way that payers can assist practices, that would be helpful. We'd also like to see continued coverage of telemedicine beyond the emergency order, and other healthcare organizations share that view as well. And we do believe that telemedicine is going to be included in the future of healthcare. It seems to be.
Just to let you know, we're working on some legislative language for that.
Oh, great. Okay.
We'll see what we can do.
We also have some concerns, and I'm sure we're not alone on this, but as more and more people, lose their jobs and go on unemployment, we anticipate there's going to be some shift over from commercial to Medicaid. And obviously that will shift the payer mix of our practices who are in business, and that could be a huge issue, further constraining our practices' finances. So we do believe that higher Medicaid reimbursement is something that's going to be needed, or something that needs to be considered. And I realize the state has their own financial pressures, so trying to find all this money is difficult, I am sure. But things if we want our healthcare system to be diverse and strong, I think as you mentioned, Senator Lyons, it's a really good time to look at the whole system and rebalance it so that we can have a strong and diverse system, so that Vermonters can get their care from there's enough providers to provide that care. I think that's going to be essential going forward.
Thank you. Thank you. I do have a question. It relates to the $100 billion fund. I guess it's CARES Act 1, that pays for medical screening, testing, and treatment for COVID patients, that practitioners can sort of bill the federal government for that money. And is that something that your folks are doing, your providers are doing? Or have they found that fund available to them?
The information about this just came out from the federal government. We have shared it with our network, and I know some of them are looking at that. So yes.
Good. Yeah, it is available, and I did some research on it myself a little bit. So I encourage all of your practitioners to access that. Now, a lot of it, of course, a lot of it's available for hospital treatment, but it is treatment for COVID patients based on the codes available. So it'd be great.
One thing that I've noticed through all of this, especially as being part of the coalition that we talk every day, our practices have been like in the forefront of like figuring all the stuff up. All the stuff out, like all the unemployment laws, all the paid leave and sick leave laws, and just all the financial opportunities available to them. And this is out of necessity, but they could teach the class now.
Terrific. All right. Senator Ingram has a question.
Thank
Yes.
you. You may have already said this and I might have missed it. I apologize. But how many providers does Health First represent?
We have 69 practices across 10 counties in Vermont, and it's about 45% primary care, 55% specialty practices, and our specialties range from everything from hematology, oncology, OBGYN, psychiatry, allergy and immunology, gastrointestinal, GI, and a bunch more. So it
Great,
really
thank you.
runs the gambit. And we estimate that our primary care practices alone care for 82,000 Vermonters. So, our practices are definitely in their communities, taking care of Vermonters, know them well, and doing everything they can to keep folks out of the hospital and just being there for them. And they're an important part of the healthcare system.
Definitely. Thank you.
I have a question. One of the things that benefits practices overall, and it really doesn't matter whether it's a hospital or an independent practice, is having a prospective payment. And yet we see that there are some self-insured groups that haven't moved in that direction. And I'm wondering if you folks have thought about building a coalition with others to ask those who are, ask the self-insured businesses and others, to ask them to move toward a prospective payment that would benefit both them and their employees, benefit you, and offer greater access to care. Have you thought about, it sounds like you're very proactive and looking at things, but have you thought about doing that? That's something that consistently, I am consistently concerned about, and I know that both Senate and House healthcare members have been concerned about.
We've engaged some with self-employed businesses, but not from that perspective. It's
there you go.
An interesting idea. Yes.
Well, one of the things that you face in establishing your reimbursement rates is the level of the power that you have, and you don't have the power because you're a smaller group. But if there are other groups and other individual practitioners who may not be part of Health First, might be VMS, might be hospitals, working together could build that power that you need in negotiations. Sorry.
Thank you.
Just my
No,
thought.
thank you.
Good idea.
All right. I'll wait to see the results. Okay. Any other questions that folks have? Wow, we're good. Thank you.
People want thank
Thank you both for being here, being
Thank you.
patient, and giving us all this information. It always triggers our interests. So thank you. And in the tradition of Senate Health and Welfare and now House Healthcare, we have finished early. So thank you all.
Yeah, thank you.
Nellie, we're good to go, so we can leave the meeting. Thank you all. Take care.
Okay. Ending live
Thank you,
stream.
Madam Chair.